Steve Carstensen. I'm a dentist in Seattle, and when I enlarged my practice to include sleep disordered breathing for adults, one of the things that became immediately obvious is that these 40 and 50-year-olds that I was seeing were at one time 4 and 5-year-olds. And so what is it that we can do to help head that off before they need to see me at 40 and 50 and 60 and 70 with all the accumulated years of body adaptation compensations for the initial problem of breathing? And I talked to the American Dental Association about that because I'm involved with education with the ADA for a long time. And they said, well, we're not really doing much with that. And so I said, what if we did? And in 2017, they formed a policy statement. So let me get started here. You can see the slides, I guess, on there too. I don't have any conflicts with anything, but what I wanted to point out with this is that down at the bottom of this screen, you can see consultant to the ADA for sleep-related breathing disorders. And it's not special that I'm the consultant to the ADA for sleep-related breathing disorders. I think it's special that there is one. And so the American Dental Association is paying attention to this part of medicine, and I like that part. So what we're dealing with here is airway pressure changes. And so when we breathe in and out, the airway can collapse behind the tongue, like Darius said, and we can have various struggles with the body's physiologic response to that closure of the airway. And early on in life, when the body is growing, the shape of the craniofacial respiratory complex, the upper jaw, the lower jaw, the soft tissues, the hard tissues that surround the airway, that's all being shaped. And we're learning that the brain response is being shaped at the same time, same part of life. So if we have these airway pressure changes that can influence the growth and development of the craniofacial respiratory complex of the brain, then if we can influence it negatively by bad breathing, bad function, bad performance, well, what if we had good performance, good function? Maybe we could influence all those things in a positive direction as well. And so that's something that we're coming to realize. It's new in medicine, it's new in dentistry as well. But hey, new things are good sometimes. When we get into the middle years, the young adult years, we're learning that those influences, that the compensations, the adaptations of the body that for those first 20 years or so are causing some changes to the brain that are important for setting up adult behavior of our whole body systems. And what if we could make sure that we allowed those influences to be positive and good ones? What if we could do something to make sure that young adults don't go through the period of time when their brains are telling them that things are going awry and they have problems like the chronic inflammatory diseases or chronic pain diseases that young adults complain about, come to dental offices and they say, I have headaches, my jaw hurts, my gut hurts, I hurt all over. And what can dentists do about that? What can we do to help them recover health at that point? Well, there's ways we can do that, because what we're trying to do is make sure that they don't turn into those adults that have been dealing with that for decades and end up with chronic diseases, chronic non-infective diseases, chronic diseases that come from overall body inflammation. And if we can do something early in life to make sure that doesn't happen, now we're changing population health and the impact of the payer system, the cost of healthcare, all these things that we can have great positive impacts, and it all comes from when we're dealing early in life. Because early in life, our physiology is pretty stable. You know, it doesn't take much for a child to be healthy. We have to do certain things, but they can be pretty healthy. But as time goes on, as we chip away at the body's physiologic stability, then what we're trying to do is avoid when things come crashing down and people have tragic events that cost a lot of money, cost a lot of time, cost a lot of trouble, cost a lot of emotional baggage when things bad happen as time goes on and the body loses its ability to compensate for all of these deficiencies they started off with. So in 2017, the American Dental Association convened a task force, and they created a policy statement, put it out to the world, It came back twice with, they did this twice, and we had lots of comments. And I think they ended up with a pretty good policy statement. It has the first time ever that dentistry took a stand on how dentists can be part of a medical problem, because they focused on sleep-related breathing disorders. Thankfully, they didn't call it obstructive sleep apnea, which is one of the sleep-related breathing disorders. They called it SRBD, sleep-related breathing disorders, so that we can see a bigger picture, so that we can be part of it. And what did they say? Dentists played an essential role in recognizing and possibly treating some of these in collaboration with other colleagues. Now, there's a lot to this policy statement. Obviously, we're not going to go through all of that this morning, but I highlighted a couple of key parts. And one of the most important parts about the whole policy statement, which went on to talk about how we can coordinate with for our adult patients and how we can test for it and how we can follow management of a chronic disease, is they said this: in children, screening through a history and clinical examination may identify signs and symptoms of what? Not sleep-related breathing disorders, but deficient growth and development, or other risk factors that may lead to airway issues. I think that's so powerful, because it's not about the performance. It's not about the end-stage diagnosis. It's about what gets them there. It's about deficient growth and development. And if a risk for these things is determined, intervention through referral or treatment may be appropriate to develop an optimal physiologic airway and breathing pattern. You'll see those words again in a minute. An optimal physiologic airway and breathing pattern. What is that? That's structure and that's function. It's not something that we measure later on. It's something that the child deals with right then. It's something that medicine has few answers for, and dentistry has many answers for, but not many recognized pathways for implementing what's available to us. And so when I read this, when I worked with this, when I started learning about the role that there of other healthcare providers, myofunctional therapists and speech and language pathologists, the breathing patterns, the folks who have been teaching about breathing performance for thousands of years, for hundreds of years, for tens of years directly to us, then we can learn how we can become better breathers, and that turns out to become better functioners. And better functioners end up to be better growers. And better growers, functioners, and breathers end up to be healthier people. And I love the fact that dentistry has taken a stand on this. And Dr. Nagel, who was introduced earlier, is going to speak to us a little bit later. He was at a conference that I convened here in Chicago at ADA headquarters in 2018 about this policy statement and how we can be players in the game. And so I think it's really important when we think about what happens for people who don't breathe well. When those 40 and 50-year-olds walk into a physician's office and they need diagnosis, we focus on certain things. And those certain things have to do with medicine. Medicine looks at a whole body picture of chronic diseases, of what the body's done to compensate for bad breathing over time, and says, well, you should do these things. And we can support a collapsing airway mechanically with an oral appliance I can make, with a positive pressure device. Now some other things that we can use as well, but it's all managing this chronic disease. And we must work with physicians on this because of those chronic diseases that dentistry has no training in. However, if we look earlier in life, if we go upstream from that problem, now we can look at it as from a whole different perspective. We can look at it from a different diagnosis. The diagnosis is not the breathing problem. The diagnosis is not the results of the breathing problem. The diagnosis is the lack of structure, the lack of function, the discoordination of the breathing pattern. So if we do those kind of things early enough in life, we can get ahead of this. We can move upstream. Dentistry is a proud claim on preventive efforts. We work to try and make sure kids don't have the diseases attributed to dentistry, caries and periodontal disease. We work hard to manage those things early in life, change patterns so that we can prevent some of those issues. Now we're learning that we can prevent airway issues over time as well, just by different ways of looking at things. So in adults, our tools that we have available to find people at risk focus on the kinds of things that are body compensations for bad breathing over decades. We have screener programs, we have testing programs that measure the body's response, the body's adaptations, the body's compensations. So fine, that's good, that's what we need. We have 1 billion people in the world, according to the World Health Organization, that have a sleep-related breathing disorder. So let's get after it. Let's get those people treated. And it's excellent that we can play part of that as dentists. But that doesn't help the kids, and we don't want to replicate that population going forward. So the ADA policy statement says this, that we have a number of multifactorial medical issues, and so that requires cooperation with lots of other parts of medicine to deal with all of these issues. That's fine. That's what we need to do for all these adults. Excellent. Excellent work. Good part of medicine, collaborative care. Love it. It's critical for us. We make, in my office, we make these oral appliances. They're like a CPAP machine for the airway. We hold the jaw forward. We keep the airway open. People can breathe. They feel better. They resolve some of their medical problems. It's an excellent care. And I make a lot of these. And I have a lot of happy patients that come back saying for the first time that they can think better. They can feel better. They're not sleepy in the daytime. That's excellent work. However, that's not the upstream work. So here we are, the recognition of suboptimal early craniofacial growth and development may lead to interventions. So I pulled this picture from something called Adobe Stock, which is just a model that they put together for whatever purposes that they do this. And this little girl's cute as can be, but this is such a scary picture to me. So when you learn to see what we can see off of these kinds of faces, then we see a face like this and go, oh my gosh, what are we going to do to help that child grow up to be healthy? And all of you seeing this picture out there that know anything about early development and growth will see that there's a lot of problems with this cute little girl that's held up in Adobe Stock to be a picture, a model that can be used for advertising or what other purposes. Now there's lots of things we can talk about with that picture, but we're not. And the other thing, the words that are most powerful is to recognize when a child is not breathing properly while they're sleeping, especially, and help change that so we can develop an optimal physiologic airway and breathing pattern. So when we see this young child who's resting well, we see that and go, oh my gosh, they're not on the pathway to optimum health. There's something that has to change here, else they're going to turn into that 40, 50-year-old that I have to treat later on. So we don't want to do that. And so what we'll be looking for is signs that we can easily communicate to parents. And when we say that, look, just look for mouth breathing. If mouth breathing is a problem because of all the things that come with mouth breathing, we have poor development, we have dry tissues, we have unfiltered air into the respiratory system, all the problems that come with mouth breathing that we could list and list and list and list. But if we just train parents to look for mouth breathing and say, well, that's not cute. That's not where it needs to be. Those little sounds they're making while they're breathing, that's not cute. That's not just growing up to be daddy. That's going to be a problem for that young child. And if we change that, then there's a lot of health issues that are going to be improved over time. And that's what we've got to look for. And kids should be able to behave well in school. One of the things we're looking for is how can we identify children at risk for bad behavior during school years. That causes tons of problems for their peers, for their teachers, for their doctors, for their school nurses, for medicine in general. What are we going to do for kids who don't behave well while they're in school? Well, it turns out many of those are not sleeping well, and they're not sleeping well because they don't breathe well. And if we can fix that early in life, well, then look what impact we can have. So you look at that smile. I told you it was scary. I got to say, look, we all look at that maxilla and go, there's not enough room for anything in that maxilla. And what happened to the mandible? We don't even see evidence of a mandible in that picture. And there may be some nutrition issues we can talk about, but it's just something we want to see as scary. So how can we identify these kids early in life? Well, it turns out that when you look and see, well, what kind of tools can we separate, when can we use to separate a population of children into who should be looked at and who doesn't need any additional intervention, there's not any really great screeners out there. So the American Dental Association put a stamp of approval on a task force, an ad hoc task force, and we've come up with a screener that we're going to validate. For the first time, we'll have a fast, simple, and easy screener. Takes 3 minutes, 5 questions for parents that can be used worldwide in any setting where children are. And when we get it validated, we're going to be able to change the practice of medicine, change the practice of seeing little kids. We're going to be able to change the standard of care. And including in that will be dentists. And that's our goal, is to be able to have impact on the standard of care around the world, sponsored by dentists. And isn't that going to be cool? So how do we help kids? We don't help them by watchfully waiting them to grow up to be bad breathers. We don't help them by expecting them to grow out of a bone problem that can only be shaped conventionally while they're 4 years old. We don't expect to help them by hoping that their bodies don't compensate and adapt to a bad breathing problem in ways that don't affect their overall health later on. We expect to help them by treating and recognizing and understanding the impact of an underdeveloped airway. That's what we want to do. That's what the kinds of things that dentistry can do, the kinds of things that the American Dental Association is at least open to. I can't say they're enthusiastic. I wish I could. But I tell you, the people that I talk to at the ADA are very open to everything that we propose, and the task force is well supported. We've had lots of meetings. They're fully behind the effort, and so I'm very proud of the American Dental Association for being part of this. I see nothing but upside for dentistry getting involved in all this, and it's going to be only, though, when we recognize that we can see where those kids are and enlist the help of other people. Because dentists in their training are not trained to intervene for an underdeveloped airway. We're trained to see that there is one. But we're also trained to recognize when we have certain skills, and we're trained to look for other parts, other professions, other skill sets to use. And in dentistry, it's real simple. If you are a general dentist, for example, and you recognize that that patient has crooked teeth, then off to the orthodontist they go. If they need something done for surgically, off to the oral maxillofacial surgeon perhaps, any number of specialties. Well, now what we do is we expand the point of view. So the dentist recognizes the underdeveloped airway and sees that, in fact, we have to see the ear, nose, and throat physician for perhaps some overgrown tonsils. And then we can't ignore the function. That's the newest part of the enlargement of knowledge base, of skills, of recognition, is to see that, in fact, it's the function. It's how the muscles respond to growth early on, how they can influence growth, how they compensate for lack of growth. And if we can help connect dentistry with the experts in upper airway function, the myofunctional therapists, the speech and language pathologists, then we can enlarge our impact that way. So then one of the messages out to dentistry is to find a therapist in your area, a speech and language pathologist who understands how those muscles function in terms of breathing, of swallowing, of all the other things that are critically important. And that's a fun message to get out there, because working with a therapist in your practice, you can see people come back with lots of great responses that you didn't expect. And that's fun. That's fun to be a clinician when somebody comes back in and says, wow, I went and saw my therapist and now swallowing feels all different and I'm breathing great and I just feel fantastic. And it was just these exercises to do. And it's a great clinical position to be in, and I like encouraging that for dentistry. So we can do little things. We can do expansion devices. We can give advice. We can be part of the therapy. We can recognize problems. There's some great books out there. This was, I guess, my favorite book out there so far, Katrina, until yours comes out, I guess. But Sharon Moore is a speech and language pathologist out of Australia, and she's written a book that's globally a bestseller, no doubt, because it should be. It's a fantastic book for clinicians. It's a great book for parents. It's one that can be handed out as a welcome to our practice for a family. It's just all kinds of things that can be done with sleep-wrecked kids, and it's a fantastic resource for us, because that's why we want our kids to wake up every day. We don't want to have to blast them out of bed. We don't want to have to send them off to school unable to concentrate. We want them to greet each day, you know, after a great night's sleep, and just be fantastic and ready to go. So the American Dental Association created a fantastic little brochure to help start the conversation. When you hand that out to parents and they look at that and they realize, wow, I recognize my child in these few paragraphs here, and what can I do about that? It starts the question making. And that's where we want to get with our screeners, with our brochures, with our conversations, with our books on display. We want to start the conversation. We want to be able to say to parents, yes, we have some pathways. Yes, you don't have to listen to them. People tell you, oh, your child will grow out of it. Oh, don't worry about that symptom. Don't worry about your child not looking like they're totally healthy. Don't worry about these things. They'll get better on their own. That's not how medicine works typically. So now we have better answers, and that's the goal. The goal is to give moms something to look for. Give moms something to go ask their clinicians about. And when moms knock on the door and say, what are you going to do for my child, because I read that this face doesn't look right, well, then those clinicians are going to have answers, and they'll reach out to us, the educators, to find out what can they do. And that's really the great thing. So what does dentistry do now? We look for kids not growing well. It's simple. We look for how we can get dentists on board. We look for how clinicians can be part of this, because today, in most of the world nowadays, it's unacceptable for a child to get all of their permanent teeth in. And if we saw that child with cavities all over the place, we'd know that that's unacceptable. We'd know that that would be a failure of the system. We'd know that we didn't take good enough care of that child to get him to that critical part of life prepared to grow into a healthy adult. What I want to do is to make it standard of care that soon it'll be just as unacceptable for that growth and development to be deficient at that same age. So if we can establish that we have to have a properly developed airway, it functions well, and that child wakes up in the morning ready to go because they have not had compromises to breathing, it's actually day and nighttime, then we are preparing those children for their maximum health for a lifetime. And that's a role dentistry can play. That's a role I'm proud to help be part of the leadership of that. I'm encouraged by all the other dentists I find that are enthusiastic about that, and I'm happy that we're going to be able to be part of that. So that's my goal, is to make a difference that way. So, who's next, Mark? Thank you.